Hello, everybody. Very glad to see you, so to speak, to know you're out there. I'm going to be talking about some new directions for dissemination and implementation research that are focused on the interface with children's mental health policies. And so I want to talk a little bit about some of the trends in children's mental health and about the changes in the healthcare system, which are presenting opportunities at both local, state, and federal levels to, to bring D&I science to bear on policy questions. And one of the reasons I think this is so important is that we want to position our research for maximum impact. It's hard to do research, as you all know. This is hard stuff. So we want to be able to position it so that it will have the maximum impact. So that's what I'm going to be talking about. How do I change to the link? Yep. All right. Here we go. So these are some of the collaborators with us in the Ideas Center, which is the center that is funded by the National Institute of Mental Health as a P50. And these are some of our partners. What I'm going to talk about today specifically are trends in children's mental health in the U.S., evolving healthcare system, as I mentioned, opportunities for this interface area of D&I and policy. A policy D&I typology that myself and Jonathan Pirtle and Sally Horowitz and others have created to try to advance this area. And then I'll talk some more about specifically about the Ideas Center and our aims and some potential data sources. So the issue around children's mental health is that more and more it is being subsumed under health policy, both at state levels and locally. But if we look at trends in children's health, we see that there are some very promising trends when it comes to improvement in children's health. When we look at mental health, however, we do not see the same kinds of encouraging trends by and large. And that's very disturbing. So I'll talk a little bit about that. I want to talk some more about the health system and the evolutions that are happening in that because of the opportunities it presents. And then talk about some of the specific health policy experiments that are going on and that are ripe, that are fertile ground for D&I science and D&I science methods. So infant mortality rates have declined over the past decade. That's very good news, obviously. We're seeing changes in that that are across different racial ethnic groups. So that's encouraging. Health insurance coverage exists for almost all US children. That is critical. There was a bit of a challenge a few years ago to make sure that things like CHIP remained, but they did. And so we do see that most children have access to some kind of health insurance coverage. However, as I mentioned, the rates of mental disorders for kids are on the rise. And it's really dismaying, it's really discouraging to be looking at this over, in my career, 25 to 30 years, and to not see improvements in those trends. Those trend lines we would like to see going down, and they're not. So we have 1 in 6 kids with a treatable mental health disorder. The prevalence rates for anxiety, behavior disorders, depression, substance use are significant and are trending up. And even more disturbing is that suicide is now the second most common cause of death for children as young as 10. So we're really seeing these very disturbing, troubling trends when it comes to children's mental health. Mental health is one thing that's measured, also impairments. Impairments are, to a certain extent, where states and policymakers pay attention, because impairments are what lead to problems in school, problems in the community, the tendency for some kids with mental health problems to end up in the juvenile justice system. So the impairments are what tend to cause the problems in functioning, normal functioning. And so those are very disturbing. ADHD is on the rise, has been on the rise for a number of years. And as I mentioned before, the youth suicide rates are continuing to go up. So, as well as psychiatric-related emergency departments. So emergency departments, psychiatrically related admissions for those are on the rise, and it's being used as almost a default system because our community-based systems are under such siege and are not up to the capacity for being able to serve the kids with these kinds of needs. So it's really a terrible picture. And it's a terrible picture. I don't know what else to say. We are not doing a good job in this country of managing the mental health problems of kids, much less getting in front of them, getting ahead of the curve, and moving services upstream. And I'll talk some more about that. There are disparities in mental health service use, significant disparities, and this is a particularly critical issue right now when we're in the context of the concerns, the public outcry about racism and the attention to the racism and the policies that tend to perpetuate it. So disparities have been long known to exist in the mental health service system. However, it's only recently that people have been willing to talk about it in terms of the terms of racism. And I think this is long overdue. It's very important. And I think it's another opportunity for us from the policy lens to think about how to craft policies that are going to address this head on. In our center, we're thinking about that very specifically. And I may have a chance to talk more about that. So one of the things that I think is a good news item is that while the research attention on things such as clinical treatment development, mental health services have been on the decline, the funding from research funding sources has been on the decline. When it with respect to those interventions, it has been on the increase with respect to understanding the various influences on mental, emotional, behavioral development. And I'm referring to many of the genomic studies, the basic neuroscience studies. There has been a huge growth in the number of those kinds of studies that are tracking the impact of various kinds of environments on the development of disorders. And this is actually creating a very strong science that I think has real relevance for policy these days. Because if you combine what we're learning about the impact of the environment, of experience, of the context on children's development, with what we know about evidence-based services and treatments and preventive interventions, the science is there. And it tells a very compelling and strong picture and paints a strong picture about what could be done, what should be done. This basically is another way of saying what I just said, which is that there's more attention to the contexts of health development. It's very much a dynamic picture. But the important thing in this particular slide is that policy is an important context for understanding this. It's sort of the last kid on the block, by which I mean there has not been much attention paid to the policy context. But when you think about it, policy is made of policymakers. It's made of the content of policies. There is a implementation aspect to it. And there's certainly a dissemination aspect to it. So in a way, it's really ripe. And when we think about the policy context with respect to children, there are many, many different questions that need to be answered, and important questions, answers to which can help advance policy. Okay. As I mentioned, the evidence base is strong across the board, and there are now entities, organizations that are paying very specific attention to how do you take evidence-based interventions across the life course. So for children of all ages, for families as well, and incorporate those into state and local policy experiments. This is from the National Academy of Science, Engineering, and Medicine. It's a wonderful report. I highly recommend it. Fostering healthy mental, emotional, and behavioral development in children. Just came out last year. And this is a report that coalesces and synthesizes both the basic neuroscience studies about children's development, along with studies about systems, and puts it all together. So it's a very impressive report. The point here, though, is that there are evidence-based interventions, of course, we know that, but the even more important point is that policymakers are paying attention to those and looking for ways to embed those into their systems. And so I think there's truly an opportunity now to do something that I think has not been the case in the past. Neil Halfon, who is at UCLA and very much a thinker and leader when it comes to health systems, specifically with respect to children, has characterized the healthcare system in terms of three transitions, I guess you could say, or periods of time. The first was basically from the 1950s to the early 2000s, the first era, which was focused a lot on acute diseases, a biomedical model, short-term timeframes, reducing deaths. So it was the initial biomedical healthcare system. The one we're in today now has an increasing focus on chronic disease, not just acute, and a biopsychosocial model. So that's important when it comes to thinking about kids. And thinking about chronic disease management and prolonging not just life, but disability-free life, which is, I think, the goal of many people. The third era, and Neil is always very good at keeping his eye on the future. The third era is where we're moving. And this is focused on life course health development. So what that means in the children's mental health area is that we're not talking about only treating children that have serious mental health problems, but also looking at ways to prevent that, to promote healthy development. And so that has real implications for our mental health system and also our other systems. One of the things that's important about this health transformation framework is that some of the ways in which the systems are designed, how they are paid for, how they approach issues around quality is very different. It's very different between where we are now and where we're headed. And so, for example, when we think about the system design, in the earlier period, health service providers were operating pretty much independently. You could hang out a shingle and provide the services. In the system right now, team approach is pretty much the name of the game. Where we're headed, it's going to be beyond just teams into community integration, where healthcare is one component among many other components, including social issues that are all going to be integrated for this life course development, for promoting health. Similarly, for the payment approach, in the past it was almost largely dominated by fee-for-service. That has changed, or is changing. So now it's much more value-based. And in the where we're headed is towards much of more of a population-based, larger budgets, global budgets that are linked to multiple sectors. So not just the mental health system or the justice system or education, but trying to come up with a payment model that's going to work for all of these systems. That's critically important for kids when you think about it. Kids with the same kind of mental health problems pop up in different systems. That has been true forever. And then those systems get in the way of creating an integrated health system for them. So these are some of the transformations in the healthcare, which have real implications for the kinds of policies that are coming out, and even more importantly, obviously, for kids' development, for kids' healthy development. So when we think about context for policy D&I, a few things to keep in mind. First, that there are many state experiments underway. I'll mention a few of them, but they're going on all over, and you don't have to look far to see them. And they're focused largely on promoting children's mental health and doing it through attention to some of the social determinants of health, and some of the social impacts. There is congressional interest, somewhat surprisingly given the administration, but there's congressional interest, a congressionally mandated commission on evidence-based policymaking and using evidence to inform decisions in government. So there's already a language for that. There are 22 states now that require policymakers to use research evidence in behavioral health. What the consequences are if they don't use it, you could say maybe that's it's not a very strong stick. However, just the fact that this is the language that people are talking about, that policymakers are aware of, or increasingly aware of research findings and increasingly being mandated to use them, is a big deal. Some of the policy opportunities, I'm just going to talk about a few. Hopefully in the Q&A that we have during the meeting, we can get more specific about this. But some of the big changes are the digitalized domination, so telepsychiatry, particularly in the post-COVID period, of course, how that is being rolled out, how it's being implemented, where the stop points are and where they're not. The CQI, or quality indicators, I'll talk a little bit more about this in a minute, but that's a huge driver of change. The family is more and more being considered the service unit. So in our traditional mental health systems, we've had an adult system, mostly focused on serious pervasive mental illness, and children's mental health system, largely focused on serious emotional disturbance. What we're seeing, serious persistent mental illness, I should have said, for adults, and then children's serious emotional disturbance. But now we're seeing much more of a focus on the families, and the families have just fallen through that crack. But there's more interest now in intergenerational, multi-generational policies that are going to deal with maternal depression, for example, as well as child health, and integrating those, which has a lot of system implications. And then there's a lot of attention now and concern about broadening the workforce, which provides opportunity for things such as using parent peer advocates. So I mentioned the quality indicator implementation. So this is an important policy issue that has research implications and direct possibilities of impact for kids. So Medicaid, which comes out of the Center for Medicaid Medicare Services, has created a child core set. So what they are saying, what CMS is saying, is that states have to report on how well they are tracking and how well they are doing in monitoring certain kinds of practices that are known to be important when it comes to behavioral health. Things such as depression screening, things such as medication follow-up for an ADHD diagnosis, follow-up after a mental health hospitalization, using psychosocial care for youth on antipsychotics before starting a trial of antipsychotics, monitoring the use of multiple concurrent antipsychotics. There are a number of these kinds of quality indicators. They're growing all the time. National Committee on Quality Assurance is very much involved in developing these. And there are, by 2024, reporting on these indicators, these measures, as well as other ones that are now being developed, will be required of all states. This is a huge policy driver. If states are paying attention to this, you know that the providers are, the agencies are. It becomes a driver for what they're attending to, what they're trying to change. It's very important when it comes to developing these to think about their impact. So what is going to be the most critical set of quality indicators that should be developed, that could be developed, that can then be embedded into the child core set? In addition, from an implementation and dissemination standpoint, these are being implemented now in health plans. We are part of a study right now with the National Committee on Quality Assurance, working with 5 health plans across the country, simply, I say simply, but it's not simple, to implement depression screening and the depression care pathway into their plans. There's a huge number of questions about how to improve the implementation of that, what strategies to use in order to improve it. This is just beginning. And as I said, these and many more are going to be required of states. So it's an example of an area where the D&I world is very much needed, and the know-how from the D&I world is very much needed to help health plans and states and communities do a better job of implementing these quality indicators for kids. Some other kinds of opportunities on the transformative change. There is more and more, as I've mentioned before, an interest in promoting children's well-being, not just treating the disorders, but actually moving upstream with services. And this means paying attention to parenting practices, to things like housing, to things like unemployment or employment, to the condition of neighborhoods, to childcare, to a whole range of things that have not fallen under the purview of the mental health system in the past, nor should they necessarily. But they are very much relevant to promoting healthy children's development and mental health. So there are a number of these that are going on right now. They're ripe for studying, both from a dissemination standpoint as well as an implementation standpoint. Some of the specific social risks that are being targeted are happening in state experiments. In New York, for example, there's been something called the First 1,000 Days. It's focused on the early childhood period with a plan to use a value-based purchasing model to be able to create a coalition of different systems and develop a series of programs to help early development of children by supporting families, supporting jobs, supporting their communities. And so it's a state experiment to see, can we actually change the trajectory for children by putting into place these kinds of integrated community efforts. There's something called the INC model, which comes out of CMMI, that's Center for Medicaid, Medicare Innovation. And that is, I'll talk a little bit more about that, but that's another example of paying attention to social risks, integrating across systems, promoting child development and children's health by focusing on families. Then there are even hospital system experiments, and Nationwide Children's is one of the leaders in that. So just a couple more specific examples. The integrated care, the INC, targets the social risk. There are 7 to 8 states that are doing it. 126 million has been supplied by the federal government to help through the states to help develop these. They are, this is largely, the money is largely to help create the infrastructure and support the programs and the delivery of it, not for research, not for evaluation. But there's a huge opportunity, as I've said before, to bring to bear the D&I science lens on these kinds of experiments and take a piece of it and say, can we study the implementation of this? Can we target the people that are making decisions about it and understand their frame? Can we target the distribution of information from a dissemination lens? So this is something that's a big deal, and it's going on right now and likely to be around for a while. I mentioned Nationwide Children's Hospital, and they have taken on a social determinants of health initiative called Healthy Neighborhoods, Healthy Families. They are, as a hospital, they've created a coalition with their community leaders, with both public and private sectors, in order to target one of the areas that is the most hard hit in Franklin County, and to say, we're going to go after housing. We're going to make sure that housing is sufficient. We're going to deal with the homelessness problem. We're going to deal with putting into place early child care. We're going to put the good behavior game into all of the schools. So they're going full force and saying what we need to do is not just be a hospital that's treating kids that come in or just doing well care visits, but rather we need to be proactive and go out and work within our communities actively. Kelly Kelleher has been the leader in this. He's a name you should know if you don't. And they're looking at the relationship of neighborhood distress and child development, tracking the vacancy rates. So they're seeing that this healthy neighborhoods, healthy families, vacancy rate is down in their neighborhoods versus Columbus as a whole. The neighborhood hires are up, and as I say, they're looking at tracking other aspects of children's health and family health over time. So they're in for the long haul, and it's a very important experiment in trying to move the services upstream and make a difference in children's mental health and healthy development. So let me talk a little bit now about the Ideas Center. So this is the center, as I said before, funded by the National Institute of Mental Health as an Alacrity Center. Thank you very much, NIMH, for giving us this opportunity. We truly are grateful. Mary McKay and I are the co-PIs of this. So it is housed in New York University and Washington University through this a joint partnership. And we also partner with the states, not just New York State, although definitely New York State, but also states across the country. So this is a national center, and we have partners. We have many partners with the National Association of State Mental Health program directors and with health departments, et cetera. This is, I think it's a unique opportunity in part because we have had the opportunity to work in such close partnership with New York State. I hold a joint position with them. So the policy lens and the research lens, we try to blend as much as we can. The questions we answer or address, I should say, we don't always answer them, but the questions we go after are ones that are foremost in the mind of the people that we work with from the state policies, policy-making organizations, which are largely state mental health authorities, but also state health authorities, state Medicaid authorities, as well as the other systems. Our center aims, we're in just started our second year, the end of May, and it's a 4-year grant. So our aims are advancing policy relevant effectiveness, dissemination, and implementation research, identifying state policy dissemination targets, and I'll talk a little bit about our first project, our P1, which is doing that. Developing early and mid-career investigators. That's where you guys all fit in, and we're very happy about that. Identifying rigorous, practical, novel methods for state policy research. So we have Larry Palinkas as our advisor, well, as our co-director of our methods core, along with Sally Horwitz, along with Robert Gibbons, to make sure that we're being practical in our methods, but also getting at questions that matter and using the best methods for answering them as well as we can. And then engaging stakeholders and disseminating findings, of course, and that's absolutely essential. Our center is unique. There are 8 centers, I believe, funded by under this announcement, and we're the only one that's focused on children, families, and state systems. We're one of 2 focused on kids. David Brent is the other one at University of Pittsburgh, so it's wonderful to have people that are focused specifically in the kids area. Our 3 projects, the first one, and Jonathan is going to be talking more about this, I know, but we've done a national survey of all of the directors of state mental health authorities who are focused specifically on children and families. So these are the directors of child and family services within all 50 states plus the Washington, D.C. District of Columbia, who make decisions about and craft policies that affect children's mental health services. This has never been done before. There hasn't even been a database so that we would know who to talk with. Jonathan and his team at Drexel have done an incredible job in getting this survey out and completed. We also surveyed youth suicide coordinators, some of whom were in mental health, some of whom were in other systems, education and health. There's also state Medicaid directors have been part of this. There is also a separate but complementary survey of substance abuse directors that Jonathan is leading. But our goal here was to understand the decision-making processes of the people that are making decisions about children's mental health. How do they use research evidence? What do they find as credible sources of information? How do the use of research change over time? What are the frames by which they interpret the evidence? And what are the big policy issues that are driving their decisions right now? So we've completed that survey, and our next step is going to be to work with Doug Luke at Washington University in order to do simulated agent-based modeling to see if you have policymakers with this kind of frame operating this kind of way with respect to research evidence, if they're in this kind of system, the state system that maybe used Medicaid expansion versus not, or a state that's largely rural or one that's largely urban, state variations, then what will be the output? What will be the kind of decisions they'll be making about children's mental health? So we're characterizing the state policymakers and looking at state characteristics themselves to be able to model the kinds of outputs when it comes to policies. So that, and the purpose of this is so that research findings, wherever they come from, our center, other people's centers, your work, anybody's work, can be crafted, can be targeted, can be framed, can be communicated in a way that will engender action. That's what we're all about, is making a difference here. And so leading to policies that are going to impact kids' mental health. So we have to understand this, and it has not been done before. We're really excited to be able to learn and to figure this out. So that's our first research project. I'm sure Jonathan will say more about it. Our second and third are focused more on specific populations and on specific problems that states are dealing with. The second one is on suicide and use of emergency rooms, and the lack of tools that emergency room physicians have in order to both screen, assess, and follow up on children who have mental health issues, including suicide, who present to emergency rooms with suicide. That one is going to get started very soon now. We've just, Bellevue is just opening up now, and we're really happy. So in the next few weeks, we'll be able to get started on that. The third one is looking at adolescents and young adults with first episode psychosis. This is another problem that all states are dealing with, is that this is a very serious problem. And one of the issues is family engagement being variable across the states and across the programs. We're wanting to understand better how to engage families very directly in the first episode psychosis services, coordinated specialty care services, in order to improve family engagement and improve the adolescents and young adults outcomes. So that one we're in the field right now in order to work specifically in New York State on that, using our family peer advocate model as a way to understand family engagement. We also have a number of pilot research projects that we're hoping to launch very soon. So this is how the studies fit together. I've already said a little bit about this, but our first study is giving us the picture of how policymakers use research evidence. Our second studies are both addressing questions relevant to states across the country, and we want to be able to target the information we learn from that so that it will get into the hands of policymakers and lead to improved care. Jonathan and myself and Sally Horowitz and some others have an article in the American Psychologist in press right now that is talking about this interface of D&I and policy research for children's mental health. And one of the things we've done in that is to try to help create a typology of what we're talking about when it comes to policy dissemination research or policy implementation research. And so this is just the way to start thinking about it. There are many more nuances and ways that I think this is going to be developed over time. But policy dissemination is largely about characterizing policymakers' preferences, their awareness of their attitudes about information with respect to children's mental health, identifying the subgroups and the attributes that that they have, so that we can better understand the way of thinking, and we can then better disseminate and target information for them, understanding the contextual factors that influence policymakers' awareness. So how do they get their information, from who do they trust, et cetera. So basically, policy dissemination is focused on policymakers both understanding their decision making, but also different strategies for disseminating information to policymakers. Policy implementation, as you would guess, is about the implementation of policies themselves. And this is where a lot of the barriers and facilitators work that has been instrumental in D&I. Understanding the perceptions of barriers from multiple stakeholders with respect to implementing policy. I gave you an example of the National Committee on Quality Assurance and trying different healthcare plans that are trying to implement quality indicators with respect to depression care pathway. That's just one example. That's just one study, but it's an example of a policy implementation study. And then there's a whole range of policy impact studies that I'm hoping will be able to get going, to look at the impact of policies that are put into place, but also to contrast one policy to another to see what's going to be most impactful. So there's a lot of work to be done. This is just giving you some more specific example, or a specific example of a policy dissemination, assessing knowledge about policy change among directors of a Medicaid managed care plan, for example, before and after a value-based care model, to create and develop a dissemination strategy. So that would be one example. An example of implementation could be assessing perceptions of policy implementation among a range of stakeholders, including families, frontline providers, et cetera, to inform the development of implementation strategies. Much as in all of research, we need to understand the phenomenon before we develop the strategy, but we want to get to the strategy, which is our intervention, in order to be able to have the impact. So it's really the same kind of continuum, understanding the context, but then developing and testing rigorously those strategies to see what's going to be best, and how can we get policies put into place so that they will be sustained, and so they're going to have the impact on the children and families. So we have a lot of data sources. In addition to the studies that are underway, which are creating data sources, of course, Washington University has a tremendous resource. We're working with Derek Brown there, with a number of administrative data sources that could be used for answering a range of questions, such as some of the ones that I've been talking about. So I just wanted to bring that up so that you are aware of the fact that we do have that available. We're still creating a process, but we think we have one for being able to help investigators who are interested in answering a particular question. For example, one of the people at NYU is interested in autism and suicide. That's not something anybody's looked at before. And so they're going to be using one of the data sources here to be able to look at trends over time and services that are being used. So there's a whole range of opportunities here, and I think it's really exciting. It's an exciting time. So just this is my last slide, a few examples of key policy issues for children. The intergenerational services, I've talked a little bit about that, but it's very welcoming, encouraging to see that so many communities, localities, healthcare plans, and states are thinking about the intergenerational services, which means paying attention to maternal health as well as children's health, maternal depression and children's health, and thinking about the family as the service unit, as I talked about, coordinating service models. If you're thinking intergenerationally, then you have to be thinking about different systems. So how do you help the pediatric system talk to the OBGYN, talk to the behavioral health, talk to schools, if you're going to create this kind of coordinated service model? People are doing it. A lot of states are doing it. A lot of cities are doing it. But it's ripe for study. Policy strategies to advance this cross systems work. So what's the best way to do it? Is it through some kind of coalition building? Is it through a contractual mechanism? Contracting is something that can be a big driver of change too. So what are the strategies for making the cross systems work? Cross systems initiatives work. Creative financing options. There's been a whole set of reports on that coming out of Academy Health and elsewhere. And Neil Halfon, as I've mentioned before, has been a leader in some of this. States are doing it to think about ways, if you're trying to fund some upstream services, the money may come out of one system, but the benefit will accrue to another system. So how do you create a sort of coordinated coalition where there can be that kind of a balancing act, especially knowing that the output from that may not be for another 10 years, 5 years, 10 years, we don't know. These are problems that states are grappling with. These are problems where D&I has a lot to offer. And so I think that, despite the really unfortunate, distressing, disturbing trends that we see in children's mental health, there truly are opportunities now to do better. The UN came up with a report about refugees and disaster called Building Back Better. And I think we're in a time when we can be doing that, particularly in the post-COVID period, particularly when it comes to children's mental health, which has suffered so much and is continuing to. We can build back better. And I think now's the time to do that. So I am going to stop there. I am looking forward to interacting with all of you next week and answering your questions as best I can, and just engaging with you, not only in the Q&A, but hopefully over the next few years as well. So thank you very much. Thank you.